Отлично.
Dear colleagues, good afternoon. Sorry for my voice. I have been ill recently. Dear colleagues, we get started, and we have a very interesting topic, and it's called thorough endoscopy. You see that we have a very interesting panel, the best leading experts in the world. Some of them you know very well, some of them you probably may not know in person, but I would like to introduce you our today's speakers, those who will take part in the discussions. The director of screening committee of the World Endoscopic Association, Linda Rabinek. Linda Rabinek, welcome. Of course, Alexander Repic, our distinguished professor, guest from Italy, from Milano, who in fact does not need any introduction. He is very well known in Russia, but welcome again on this association. And Michael Hafner, a very distinguished guest from Vienna, who gave a splendid report at the previous session. Michael Hafner, thunderous applause to you. Zalina Galkova, the chief specialist on endoscopy and gastroenterology, participant of many trainings, great speaker. Thunderous applause to Zalina Viktorovna. Kirill Shishin, professor, head of endoscopy department of the Moscow Clinical Research Center, Department of Healthcare in Moscow. He, as nobody, is involved in this field. Kirill, welcome. And Sergei Kashin, our great specialist who is well known to all of you, the chief specialist of healthcare of the Yaroslavl region, the head of endoscopy hospital in Yaroslavl. Sergei, thunderous applause to you. Dear colleagues, the topic quality of endoscopy, artificial intelligence in endoscopy are very relevant topics, modern technologies and so on are going to be discussed within this session, which are of high importance to all of us. And now I would like to give floor to our distinguished guest, Professor Linda Rabinek.
Thank you very much, and good afternoon, everyone. It's a real privilege to be invited to participate in these meetings, and I'm very grateful to my good colleagues Sergei Kashin and Yevgeny for the invitation. I want to talk very briefly about quality in colonoscopy. We would all see this big stock, but if the prep were like this, and we've all seen preps like this, would we see this small lesion? You can see the biopsy forceps up against it. Would we see this? So why might we fail to detect these lesions? Either we don't see it, or there was a lesion and we removed it, but we did not completely remove it, or maybe there was nothing there and there was a growth that happened after the colonoscopy. Those are the three reasons. Well, there's increasing evidence that it's not so much a new growth. There's increasing evidence that mainly it's a quality issue. And this was a large study in the US, and they estimated that those cancers that were not detected at colonoscopy, that occurred and were diagnosed within 4 years after the colonoscopy, 75% of the time the lesion was either missed or there was a polypectomy, but it was incomplete. So it seems like most of the time it's an issue with quality rather than biology. So we published this paper now 10 years ago, and we made a definition of post-colonoscopy colorectal cancers. And the importance of post-colonoscopy colorectal cancers we'll talk about in a minute. And I'm going to focus mainly on two quality measures. One is adenoma detection rate, and I'll explain why, and the other one is post-colonoscopy colorectal cancers. Both are important, but in different ways. This was a study from our colleagues in Poland. They had over 45,000 screening colonoscopies done. They had a large number of endoscopists, and they found when they followed these people over time, they had 42 people that had a post-colonoscopy colorectal cancer that was not found at the colonoscopy. And here's the important graph that shows on the vertical axis is risk of new cancer, and then you can see follow-up time in months up to 5 years. And you can see there that in the dark line, those who had their procedure done by an endoscopist who had a low adenoma detection rate, less than 11%, they had the highest risk of subsequent new diagnosis of colon cancer. Those in the orange had their procedure done by a colonoscopist with a high adenoma detection rate. They had a low risk of subsequent cancer, and it remained low for 5 years. So this was the best evidence and the first strong evidence that we had that there's a relationship between an endoscopist's adenoma detection rate and subsequent cancer. In the US, in Kaiser Permanente in California, the subsequent study went one step further. They had a large number of colonoscopies, a large number of endoscopists, they had a larger number of subsequent cancers, and they were able to look at the adenoma detection rate in 5 different categories or quintiles. And here we see on the vertical axis the risk of cancer, and on the horizontal axis the 5 different categories of adenoma detection rate. The lowest detector are the quintile 1, and the highest detectors are quintile 5. And again you see that there's a relationship, and for those people that had their colonoscopy done by a high detector, quintile 5, they had the lowest risk of subsequent cancer. So we have the Polish study and now the US study that shows us that there's a relationship between adenoma detection rate and subsequent cancer. The US study went one step further, very importantly showed a relationship between adenoma detection rate and death from colon cancer, fatal colorectal cancer, and here you see the relationship. So in this study, if you had your colonoscopy done by a high detector, you had a lower chance of dying from a subsequent colon cancer. Very strong evidence. So the WEO Colorectal Cancer Screening Committee put together a working group and developed consensus statement on the definition of post-colonoscopy colorectal cancer, and that was published just 2 years ago. And the definition then put forth is a cancer that appears after a colonoscopy in which no cancer was diagnosed. The report also showed us how we should calculate the rate and how we should report it. And what the recommendation is, and this is now at the unit level, not at the individual endoscopist level, because for an individual endoscopist, the number of post-colonoscopy colorectal cancer in any one of our practice is a small number. So you really have to have a larger group to be able to assess this. So it's measured at the unit level rather than the individual level. Adenoma detection rate is measured on the individual level. So the recommendation is that for our unit, our endoscopy unit, we review all of these colorectal cancers that are diagnosed in the year, review them all, and then identify those that appear to be post-colonoscopy colorectal cancers, and then we report it. We report our 3-year rate of post-colonoscopy colorectal cancer. That's what we should be doing in our units. That's what we should strive to do. So here's a very nice example from England. This is a paper that's in press in the British Medical Journal. Nick Burr is the first author. And here you can see all of these hospitals in England. And you can see between 2011 and 2013, all of these hospitals, they measured at the individual hospital level the post-colonoscopy colorectal cancer rate at 3 years. And you can see the mean, 6.5% of cancers were post-colonoscopy. And you can see the average for the bowel cancer screening program. The endoscopists that are doing the endoscopy for the bowel cancer screening program have a lower rate of post-colonoscopy colorectal cancer. So would you like to have your colonoscopy done at one of the hospitals on the right-hand side of the graph? Or would you rather have your colonoscopy done at the hospital on the left-hand side of the graph? So this is a very nice example of where we're all striving to go with this measure. And so the recommendation is that we do a root cause analysis. When we identify a post-colonoscopy colorectal cancer, we review the chart, review the endoscopy report, review the pathology, and do a root cause analysis to see the reasons why. Before I stop, just one comment, because I know that Sergey and others will be talking about colonoscopy upskilling, terribly important. And the Canadian Association of Gastroenterology has this C course, Skills Enhancement for Endoscopy, and a number of centers around the country where a person who's a practicing gastroenterologist and endoscopist can go and improve their skills. And I think this is terribly important, and I know Sergey is going to talk about the very nice work that's going on here in Russia. So in summary then, adenoma detection rate is our best quality measure for the individual endoscopist. Post-colonoscopy colorectal cancer is a measure for the whole unit or the hospital, and I've just emphasized the importance of upskilling. And just finally, before I stop, a commercial plug. The WHO Colorectal Cancer Screening Committee, these are open meetings, and our next meeting is at UEG Week in Amsterdam, the Friday before UEG. These are open meetings, and send us an email and put your name on our list. You're welcome to attend. And I thank you very much for your attention.
Спасибо большое, Линда. Давайте поприветствуем докладчицу. Уважаемые коллеги и президент.
Linda, dear Presidium, are there any questions? My co-moderator Sergey Hashin has a question. Or are there any questions to Linda? Yuri? In fact, you have a very simple mission to moderate this session, because despite it's a very complicated topic, thorough endoscopy should be based on the standards and recommendations. And you are one of the key leaders in developing a block of recommendations and standards together with the chief specialist of the Ministry of Health of Russia. Therefore, I believe that the report that we just heard, Linda showed us how important it is to go in line with the standards and how it may improve our work. And it allows to protect patients, reduce risks, and improve mortality rate. If you talk about colorectal cancer, I think in our country it's a very hot issue. It's a key thing to establish such recommendations, because as for endoscopy, we still use international standards that are not validated for 100% by the Russian Ministry of Healthcare. Yuri, you are quite right. It's a very good comment. We do a lot in order to improve the situation so that our endoscopy specialty, gastroenterology and surgery, get all the necessary clinical and hematological recommendations so that we can move forward and diagnose better our patients and protect their lives. Well, dear colleagues, let's give thunderous applause to Linda for her fabulous report. Linda, thank you very much. And now I would like to get back to the issue of quality of diagnosing upper parts of the digestional tract. Sergey, the floor is yours. Dear colleagues, dear friends, we've been talking a lot about standards that our group has been introducing via the project of the quality of endoscopy. But it's time to talk about training project, educational project that has been initiated by the Russian Endoscopy Association and Profile Commission within the Ministry of Healthcare of Russia, and is a primary focus by Yuri Gennadievich Starkov. This educational project covers standards of endoscopy of upper levels of digestional tract. And today, when we were interviewed together with Micah Kaufner, we said that it is very complicated to perform endoscopy of this part of digestional tract, and it is very difficult to implement those standards and apply those standards in practice. Therefore, yes, and it's not an issue of Russia only, but a very big challenge for European countries too. I will tell you briefly what has been done in Russia in this field. And it's a great addition to the project to call that was initiated by Alexander Repichi in 2014. Well, despite, well, of course, focus on the incidence of colorectal cancer and standards of colonoscopy is quite obvious because the most difficult situation, if we talk about cancer incidence, is certainly first in colorectal cancer. But despite the decrease of stomach cancer incidence, we still see that it's one of the biggest pathologies in the structure of cancer structure incidence, and we see the growth of esophageal cancer has been detected in Russia, and in 10 years 13% growth is a big effect. If we talk about esophagus cancer, we see that only 13% of esophagus cancer are adenocarcinoma, while in the US and European countries like Sweden, Australia, and so on, 50% account for adenocarcinoma, and esophagus by Barrett, and perhaps such a disbalance can be explained by the fact that there is a lack of, there is a gap in early diagnostics because the cancers that are detected in the distal part of esophagus, they are classified as cardioesophageal cancer and recorded as stomach cancer. So here we should understand that we have to focus on the early diagnostics of neoplasia of esophagus, and Kirill Shishin will be talking about initiatives in diagnosis of esophageal or esophagus, and in that regard lots of things will have to be done. Challenges. What challenges do we face in Russia? Well, talking about the stand-up project, the biggest challenge is endoscopists and the gastroenterologists are the different specialties. In most cases, endoscopist is a specialist that was previously a surgeon, and most nosologists that are sent to endoscopy of upper levels of digestional system, they are gastroenterological patients. The main idea of this project for Russia is to unite gastroenterologists and endoscopists by one standards, common recommendations, and educate, upgrade their qualifications, which are very important in their work, and endoscopists should get basic knowledge and standards of diagnostics of gastroenterological pathologies. And on this chart, you see the second challenge is disproportion between colonoscopists and gastroscopists. That also reflects a unique situation of Russia. So during the start of the stand-up project, we saw that quite many endoscopists are prescribed without conditions, and there is a failure to follow the standards, and therefore gastroenterologists have to send a patient for another gastroscopy, and it's that costs a lot to the Ministry of Healthcare. Stand Up is a unique initiative for Russia. We started in 2017. You see the initiating group that Mikhail Albertovich Murashko supported this project at the beginning, together with Oksana Drabkina, who understood the importance of standardization. And the expert group was headed by Ralph Bishops, who is a key expert of European Endoscopic Association, and he heads the quality committee. He is an author of contemporary standards that allow European Endoscopic Society to promote the standardization ideas of endoscopy of the upper level of digestion tract. The main idea of this project was to improve communication between endoscopists and gastroenterologists, discussion of current global standards, and launching new recommendations for endoscopists and other specialists. Here on this slide you see a group of experts, endoscopists. You see here Mr. Korolov, President of the Russian Endoscopy Society, Professor Starkov, which was very important for the image or reputation of that project. So medical society understood they were experts who took care of the modern endoscopy and developing standards in Russia. The gastroenterology group, experts team, top leaders of Russia, and main topics that were discussed at the latest trainings, Barrett esophagus, early diagnosis of lesions in esophagus and stomach, modern standards of treating patients, accent to the recommendations of MAPS2 of the European Society, diagnostics of functional diseases and rare diseases like eosinophilic esophagitis. And thanks to the work of our group, the awareness was raised throughout Russia regarding those problems. In fact, rare diseases turns out are not very rare if they are diagnosed on time. During this project, we launched very important and innovative training courses. So we call them tandem lectures of endoscopists and gastroenterologists that discuss the same problem, and shows the view of endoscopist on that problem, and from the other side the view or opinion of gastroenterologists, which is very important if you want to take a consensus. There were very hot debates with pediatricians, pathologists, surgeons that in fact bring us together if we want to develop standards of these procedures of endoscopy for esophagus and the stomach. Also interactive voting, live and voting. When we conclude the first stage of this project, we will understand what is at the basis of Russian Endoscopic Society and what problems are important and relevant to them. Also, live demonstrations were very important too. We did it during a few stand-up courses, explained the standards of diagnostics, as you see in this video, regarding Barrett esophagus, using innovative endoscope pentax that just had been launched in Russia at that moment with a magnitude of 136 times. And you see that together with Professor Bishops, we do diagnostics and show doctors the modern standards for diagnostics of neoplastics, neoplasia, lesions in patients with Barrett esophagus. Also, it was a great field for young patients, for young professionals to be involved in the association activity.
To present their vision and their fresh view on existing problems in our country. And of course, there was a huge audience and lots of halls in all of the cities. Practically, stand-up courses had around 250 and 300 attendees. And of course, that's a lively atmosphere and environment. And there were interviews from leading experts who during the breaks were giving interviews to and also sharing their opinion, maybe not the official one, but their professional opinion on different problems related to standardization of endoscopy and gastroenterology. At each course, we try to interview not only the experts, but the listeners, the attendees, and based on this interview, we could also change the program for next training courses so that we reflect the problems of concern for the expert. What was fantastic atmosphere that we had from Quacol. The first cake was cut by Alessandro Repici, and we continued that tradition together with Rolf. That's a movie. So the first medical channel prepared a small video from G-Days last year. So the first stand-up took place in innovative clinic at Skolkovo, in the new medical cluster there. So there is no sound. And in this video you may see how many cities participated in the conference and the main topics which were covered in terms of standardization in gastroenterology of upper intestinal tract and endoscopy. That's a pity we don't have the sound. And another activity were translation of new standards and guidelines. You see the activities of our groups. And the last recommendations of ESG on the quality of endoscopy on the upper GIT, on the MAPS guidelines. I will speak in more details. In 2015, we initiated first Russian MAPS symposium. This is for patients with cancer lesions in stomach, gastric lesions, and now we'll shortly see MAPS 2. So you see esophagitis here, the technical aspects of high-resolution esophageal manometry, and this is important component when we make clinical management plan for patients with different pathologies of GIT. As a good example of implementation of these standards is the example of Yaroslavl region, where healthcare department issued a decree on standardization of imaging of our endoscopic diagnostic test. I mentioned that in the morning in my presentation. And also we promote those ideas and technologies on our website, endotube.ru. You can find materials about Quacol and Stand Up and the opinions of our leading experts. And endoscopy cannot exist without standardization and cannot exist without modern guidelines which will help our doctors and our gastroenterologists to move together forward and to understand each other more and cooperate with each other and be friends with each other. These are important aspects of endoscopic initiative. Thank you very much for your attention. Thank you, Sergey. Dear colleagues, dear Presidium, maybe Michael or other colleagues have some comments.
Congratulate Sergey and everybody who contributed to those quality assurance programs. In Europe, as you've seen from the ESGE guidelines, we only recently defined quality indicators for upper GI endoscopy, but so far, at least that I know, not many countries are actively promoting those quality criteria. So kudos to the Russian group that everybody helps together and works together to promote those guidelines so they actually arrive in clinical practice.
Thank you very much. Sergey, what's your reply? Yes, that's mostly a comment. And I am grateful to Michael for his active participation in this project. The key result is today the results of Quacol project, led by Alessandro Repici, and we managed to demonstrate the real results of training sessions, training courses. It impacted dramatically the ADR and also our practical work, and we increased the accuracy of identification of malignant tumors in rectum, and we need to do the same for upper GIT, I think, to make standardization there. It's a little bit more complicated. We'll try our best. Thank you very much for your comments. In a very natural way, we are moving towards the presentation of Mrs. Gankova. Zarina, you have the floor. Good afternoon, dear colleagues. So I will speak about other things, and I will not repeat about colonoscopy, and I will not speak about the whole of Quacol. I have the question to audience. Who did screening colonoscopy? So there are few of you, so maybe you're young here. And quality indicators of colonoscopy, which were introduced by ESG, and those who were implemented under Quacol, they are widely discussed. If you did not see that, so it's available online in open access. And very briefly about the key points. The first thing we should do, increase the number of colonoscopies. In Russia, probably very few hands raised among our participants is a proof that we are not motivated enough and to do this type of diagnostics. And we need to improve the quality of preparation for colonoscopy. And Linda showed if it's like this, like in the left, the image to the left, we won't be able to find all of the pathologies. The intestine, the bowel should be clean. It's the same patient actually, and at the bottom we can perfectly see this lesion, and if the preparation is bad we will miss it. Another important thing we need to mention, and the two-stage preparation should be the standard, and there is a morning preparation option, and we started to use it more in our country, and you should never use the evening preparation. And it was proven by two Quacol studies. So the gray columns, what was in 2014, we see that evening was in preparation was in 75% of cases, which should not happen in endoscopy, and two-stage preparation is in 63% of cases. And that's a great success of this training project. And of course, adequacy of training improved as well. And we got to the minimal recommended threshold is 19, in line with the European guidelines, and for Quacol 2 we achieved 89%. This is a very good result, and we hope to improve that further. Another important thing, we need to do total, complete colonoscopy. It's about trainings for how to use equipment, and our teachers and lecturers, they really invest a lot of time into this, and you could also get training from our wonderful endoscopic companies. You could just try to do colonoscopy here, the assembly. Now we have the final stage of colonoscopy competition, and from our session we will go there to see who's the winner this time. What we achieved with our training projects and training on techniques. So the frequency of cupula, of reaching cupula, increased to 96% from 86%. If in Quacol 2.1 we did not assess the cupula of the blind guts, so now we have that in routine practice. And now with a well done preparation and good colonoscopy, we need to find these pre-cancer lesions, and all of the endoscopy doctors, they use peer-risk classification. We all understand each other, why we use it, and what we should do next with these lesions. We started to understand what is adenoma detection rate, because before that nobody knew that in Russia, nobody calculated AZR. And this indicator, so Alessandro helped us to make the calculations with the help of his system, which was making all of the assessment for our project. So the minimal standard is 25%. And if it's too low, we can increase it. And if we improve the indicator, it decreases incidence of colorectal cancer. And we also exceeded the minimal ADR threshold. In split mode, it accounted for 30%, which is really good. Another important thing I would like to mention, we need also to remove the lesions that we found. I would like to ask our international experts, does the screen colonoscopy include the lesions removal? Can you answer very briefly?
As long as the lesion is removable less than 3 centimeters, no big sign of invasion, we remove the screening colonoscopy.
Вы удаляете, Майкл?
Yes, same in Austria, and we're now trying to reserve slots for patients with larger polyps inside the hospital. So if outside the hospital a polyp is diagnosed which can't be resected, the same day, the same bowel preparation, the patient receives a colonoscopy with polypectomy in the hospital.
Линда, и вот то же самое у вас? Вы удаляете...
And Linda, do you remove immediately the lesions that you find the polyps?
We do, but like Alessandro's example, only if it's up to a certain size. We expect everybody who does screening colonoscopy to be able to remove up to 2 centimeters. Everybody, do it well. But if it's larger than that, then it needs to be sent to somebody who has more skill. And we're in the process of implementing that, how you regionalize the referrals to a unit where you have more advanced skills. Yeah.
I see. Спасибо большое. То есть в скрининговую колоноскопию действительно...
And so the screening colonoscopy also includes a removal of the lesion found. So what happens in Russia? There are lots of discussions about biopsy. How does it happen here? In outpatient clinic, a patient gets colonoscopy, and unfortunately, in most places, they do biopsy. And unfortunately, the patient stays with the lesions, then he gets consultation of the surgeons, and he gives him a long list of diagnostics. And then I have a question. Very briefly, colleagues, do you do biopsy? You answer that no, because you remove immediately, then we are not going to waste time on that. A big list of analysis is given to the patients for polypectomy, and this preparation list is the same for polyps and intraduodenal resection. And after the poor patients took all of the tests, he gets to repeated visit to the doctor. After that, he gets to the hospital. And then I have a question. And your patients, do they have a big preliminary testing before the screening colonoscopy, which may include polyp removal? Do you do any extra diagnostics for the patient? Blood tests, ECG?
And we also keep the patients on aspirin. We don't stop the aspirin.
No lab tests. Patient stays on aspirin unless it's a very large lesion.
Same.
То есть то же самое. То есть весь мир не проводит...
The whole world is not doing any extra diagnostics, which our country can afford, apparently, and that's in the guidelines. Only selective tests are required, not in a routine way. No coagulation tests, so we will not spend time on that. In the hospital, the person gets a repeated preparation for colonoscopy, repeated colonoscopy, only that the polyp is removed. And that was his purpose the first time in the clinic. And then he stays some days in the hospital. So it's outpatient and inpatient stages. They contain repeated on overlapping activities, and that's not clear why it's happening. We are duplicating different activities, and it's not cost effective. We realize that, especially if we are talking about national screening where the state, the government will allocate funds. Why should we duplicate the cost? It's not clear. So from our current situation, so we need to remove those stages which duplicate each other and remove polyps when they are found. Going back to biopsy, it's unnecessary completely. We need a polyp removal, which will provide for morphological assessment, evaluation of this lesion. And without changing the tactics, biopsy increases fibrotic risks and other complications, and small polyps are hard to find, and many who work in the hospitals very often face the situation when they cannot find polyps, because the biopsy had 5 fragments from a 3 millimeter lesion and it's not there. When the biopsy is necessary, like in this case, when there was the patient sent for dissection, and after thorough diagnostics, there was an invasive infiltrated lesion that was an advanced cancer which cannot be removed endoscopically. Before surgical removal, biopsy should be done. That's a must. And how we can remove them? There are guidelines from ESG. We need to remove everything except for hyperplasia lesions in rectum. And here in the guidelines we can see the methods of polyp removal. And here we would like to focus your attention on the following. In over 80% of the polyps in the rectum are small ones. In the large bowel they are less than 10 millimeters, and over 25 millimeters, the big ones, that they will be treated and by our colleagues, by surgeons. There's only 30% to 3%, and these are small lesions. Of course, cold polypectomy helps us. That's a wonderful solution, and now in Russia we use this method more and more. And of course, if the site is bigger, we do resection of mucosal layer, and if it's up to 2-3 centimeters, it can be done in outpatient clinic. And we answer this question. When there are big lesions, so it's done in a hospital. There is hospitalization for a more expert work of this section, because very few doctors can do that in outpatient clinic based on lesion size. So the necessary conditions for outpatient polypectomy, experienced doctors, of course, proper equipment, because in clinics the doctors not have the tools to remove those polyps, and of course assurance of quality standards that we spoke about. How it's happening in Moscow? Endoscopic service in Moscow is being changed. Endoscopy from outpatient clinics will be moved to those expert centers which will be opened in big hospitals and oncology centers, which are not replacing endoscopic department in those hospitals. Endoscopic departments will continue their emergency work and complicated interventions. But those expert endoscopy centers that are being designed, they will provide for preparation for colonoscopy and also for surgeries, diagnostic endoscopy. It will be expert level endoscopy with all of the quality criteria, and will be able to assess the results of these expert centers. And also we will have the info about ADR, how many cancers were missed. It will improve the work of those centers, and also polyps will be removed at diagnostic stage, at screening, colonoscopy. And also there will be anesthetic doctors working, and it will improve the quality of diagnostics, and it will give a chance to more patients to come to that painful diagnostics, and as anesthesiologists will improve the work of those centers. And we need to review the tariffs of obligatory medical insurance, of the reimbursement, and the medical insurance will cover the work of those centers, including equipment and instruments which are necessary. Thank you for your attention. About Kvakol, you have all information online. Thank you, Zarina. That was a wonderful presentation. I think it gave rise to many ideas and thought in your hands, and many questions for discussion. Michael, Alessandra, Linda, do you have any questions or maybe comments? Linda, please.
Maybe just a quick comment. Terrific presentation. Thank you. I think what the presentation highlighted is when we talk about quality of endoscopy or colonoscopy, it's more than just the individual procedure. It's also how you organize the delivery of the service to a population and how you sort out where the procedure should be done, which procedure should be done outpatient, which inpatient, and how the flow of patients should be organized. And that organizational part of it is so important, and I think your presentation really highlighted that.
Да, спасибо за комментарий, Майкл.
Thank you for your comment, Michael.
Well, I fully agree with you, Linda, and there's one point I would also like to underline is sedation for screening. I think we're dealing with healthy individuals which usually voluntarily come to us, so we have to make sure that we reduce the fear, we reduce the burden of an invasive procedure. So in Austria we try to make the sedation part of the quality criteria. So everybody who's undergoing screening colonoscopy is offered sedation as well.
Спасибо большое. Пожалуйста, кому еще угодно.
Who else would like to say something? Alexander, Kirill?
I was curious to know if you get involved also the nurses in this program, or if there is any dedicated program for the nurses.
Ну, к сожалению, сейчас
Well, unfortunately, there are no special training programs for nurses, but partially at different conferences on endoscopy, we have nursing staff. But within Quacol and Stand Up, we did not do that for nurses. They attend our projects as well, but they are not especially active. And that was a very good suggestion, Alessandro, by the way. That was very good to involve nurses into Quacol. Thank you, Kirill, you have the floor. Some comments. Yes, a small comment, quick comment. Like endoscopy doctors, so we all participate in treatment process, and we live in a legal and financial field. And yes, of course, Zarina spoke about many problems. They may not be related to bad quality of endoscopy doctors. We are obliged to live in legal frameworks that exist in the country. Of course, it's clear we are discussing our medical questions mostly, but I think we need to talk to organizers of such forums so that they change the legislation basis so that we save money for them. And we are also interested in saving costs.
So we are interested in improving the process, but we do understand we can't break the legislation, the law. We are ready to do colonoscopies for patients, certainly, but we have to go in line with national regulations. If we do a surgery, and if it's a procedure is described as a surgery by the Russian law, we have to do procedures that are associated with surgeries to take some tests and so on. Unfortunately, it's not an issue, of us. It's more. We have to live in the conditions that we have, and we have to operate in those conditions. I do understand your pleas, but we also have some pleas. I quite agree with you. I hope that these expert centers of endoscopy, they are going to be considered as pilot projects, and we will see upgrades in Russia, at least in Moscow, in the city of Moscow, and then we will be able to use this best experience in other regions. Plus, we hope that Yuri Gennadievich will help us to upgrade the law. Thank you very much for your trust. Very good. Let you hope. Yes, I will let you hope, but just listening to your report, I realized that we have to come together, to get together and discuss these issues again. I'm talking about some organizational issues, and come up with some strategies that we should implement in life. Kirill has been saying a lot that these are the key things that allow us to improve our work. The funds, financial issues is another thing. We should understand there are pros and cons in each situation. It's a tricky situation, but certainly initiative and ideology is very very interesting. So we should remember that patient should be in the focus of our attention, but lots of things are to be discussed. Dear colleagues, do you have any questions? You have a question? Okay. Do we have a mic? Thank you very much for such an interesting report. I just wanted to ask, if you talk about capsule colonoscopy and virtual colonoscopy in such centers, can they be used in such in such centers? Talking about capsule endoscopy, certainly it has a niche in the field of endoscopy, but it regards a limited number of patients. Capsule examination should be done in a larger center, in each outpatient clinic or a center that will provide endoscopy. It doesn't make sense to carry out capsule endoscopy, so expert centers probably won't offer capsule endoscopy. Probably very few of them will provide such a service. Let's ask opinion of our foreign leaders. Linda, what do you think about capsule?
In colorectal cancer screening?
I think so far, Sergey, the evidence is not good enough to use it for screening. It doesn't compare very well with colonoscopy, for example. Maybe as it evolves, as it gets better, the technology, maybe, but today it's not recommended.
And also we have the issue of bowel prep with the capsule. We're still not able to get the bowel prep enough.
Yes, and in case a polyp is found, the patient has to undergo another bowel preparation, which is actually the nastiest part of screening colonoscopy when it's done in sedation. And as for virtual or CT colonography, you have the problem that spatial resolution is not high enough to detect flat lesions. And now in recent years we've been trained, and we train our doctors to look especially for flat lesions, as they seem to be the more dangerous ones, especially in the right colon.
Спасибо большое.
Thank you very much. Okay, dear colleagues, I think it's time to move on, and I would like to give floor to Kirill Shishin. Yes, let's give applause to Kirill. It's a very good idea, in fact. Dear colleagues, dear panel, my goal was to tell you about practical elements of practical procedure of practice in our clinic, and I will be talking about Barrett esophagus. Lately, there are quite many clinical recommendations from ESGE. Issued in 2017. There was an update in 2019. Russian Association also launched recommendations in 2014. Russian Surgeon Association also revised their standards in 2015, and Department of Healthcare of Moscow launched clinical recommendations in 2019. So these clinical recommendations look like this. If you Google them on the internet, you will certainly find both national and international recommendations. So the interest to it is that there are quite many questions that have to be discussed in this regard. And on the stand-up program, we do understand that it is important to revise our knowledge and findings in this nosology, how to make right diagnosis, where to do examinations, who should involve in diagnostics, why do we discuss it within multidisciplinary cooperation of medical specialists, shall be done biopsy or not, how shall we monitor the patients, how to treat patients, which patients should go through endoscopy or surgery, how to combine traditional interventions with endoscopic procedures, and is anti-reflux surgery shall be regarded as anti-cancer, and if it is applied, in which cases, and how to follow up patients after the treatment. I don't know why Barrett esophagus is discussed so lively, but probably because it's a very complicated disease, and a Moscow doctor, as a Moscow doctor, I actually tapped into that program and was quite surprised that about 10% of the questions were on the Barrett esophagus, and my error rate was quite high, even though I've been working in this field for quite a long time. So what shall we know, what shall we know about this? Regarding that, not all lesions we see can be regarded as Barrett esophagus, so we should exclude such a phenomenon as ultra short esophagus, and in those cases when we see a picture as you see on the video, within the length is 1 centimeters, we can make an arrow and think that it's metaplasia that is being taken place with the long esophagus and stomach reflux. We certainly know how to use endoscopy with endoscopes with higher resolutions. We use color agents in order to identify better the zone of epithelium and changes that could take place there. But unfortunately, most of the patients that get medical service are the patients that are patients with unregular transfer line of epithelium, and they do not need any endoscopic treatment. They are patients for active monitoring, not even active monitoring, but at the same time they are the patients, the most active consumers of endoscopic procedures like high frequency ablation and so on. So they require us to provide any treatment. They start to complain to the Ministry of Health and so on. But you shouldn't follow such requirements because you should find a solution for those patients. Anyways, we should look at the risk factors of Barrett esophagus, and you have a young lady who requires to be treated, and she has a body index of 8. So we should understand that this is a patient that shall be regarded as a potential risk of Barrett esophagus development, and especially if he smokes. So this is our typical patient, but it's very unlikely that a young woman may have this disease. What is not a Barrett esophagus? It's inborn congenital stomach ectopy that with a good examination along with the standards, I'm talking about endoscopy under sedation, that gives more opportunities to examine disease of patients with hernia. So that was a procedure we were doing, but the patient was more interested in the ectopomy, and first of all, this condition should not be regarded as a developed disease, and certainly this female patient does not need any endoscopic treatment, even though there were some signs of carcinoma described. What did we change on the market of Russia? We understand that we should use more frequently the best endoscope that we have on the market and use all the functions that it offers: electronic formoscopy, better resolution, use color agents, and pay attention to any lesions. There are quite many functions in this equipment that must be used during endoscopic procedures. And if we talk today about quality standards, we should understand that if it's a first examination for the patient, it depends on his luck and what endoscope he will be used for him or experience of the doctor. So if depends what expert center he will be sent then, and then certainly we will do a protocol of examination, and that protocol should include sedation as a non-mandatory element of examination. Just if going back and seeing the potential patient of with the risk of Barrett and Barrett esophagus, this is a typical patient that does not undergo well this procedure. So, and this is why sedation is a very good thing to do. Certainly we need more time. This slide is shown in many presentations. Certainly it's not my original slide, but it says that all lesions together with metaplasia are detected when you have more experience and you with more time, and you see them at the 5 or 6 minutes. So it's a time-consuming procedure that shall be done again with sedation. We certainly use our terminology and classify the diseases using the Praga criteria to define the cylindral segments of circular lesion, segment of proximal lesion, and so on. Very often people come with wrong measurements and with axial hernia. This segment of stomach that is located in the thorax sits higher than the diaphragm, and there is a chance to make an error in the measures. So protocol of biopsy is being discussed today. All protocols are written to everyone, but not every clinic has good equipment. And if there are no any pathological lesions, we should give biopsy. We should take biopsy in order to make sure there are no dysplasia in metaplasia segment. It's a quite aggressive protocol, so there are some annexes to this protocol, but depends again what equipment you use. If there are additional methods that allow us to detect some mucosa parts with a risk of lesion, so probably you can make a step aside from this protocol. The most important is how to make a biopsy or how to report the biopsy. Here you see rough bishops that says that there is we should remember there should be target biopsy when we see lesion, or blind biopsy when we don't see anything, but we should take biopsy at 4 squares of 2 square centimeters. They should report should look like this. If it's a blind biopsy, we use one flask, vial, yes, and the target biopsy should be described as we see on the slide, so that if cancer is found, it would be easy to understand the location of the cancer tumor. As for the treatment, there are quite many ways, approaches. If it's a disease on the early stage, there should be endoscopy performed or surgery without any particular form, or it should be a follow-up, depends on the dysplasia level, presence of carcinoma, and so on. And why endoscopists are interested in this disease? Because endoscopists, they have a mission to understand whether endoscopic treatment is not relevant already, or it's not yet relevant, or which treatment should be the best, most efficient for the patient. So there are quite many questions to be answered. It would be you would think it would be easy to exclude patients that need surgical treatment, but we should understand the depth of invasion of the carcinoma or tumor, but sometimes it's difficult to evaluate, and endoscopic characteristics are more reliable. And remember that mucous resection can be a diagnostic procedure when we can't understand whether the lesion is a tumor or not. And then morphologist, as a part of multidisciplinary team, can give us an answer whether it's adenocarcinoma or not, and if it's an adenocarcinoma, the depth of this carcinoma, whether it's limited by the mucus or it is deeper. Then we understand the strategy of the treatment, whether this patient is candidate for endoscopy or for a surgery. And the one important issue is who should carry ablation. It's quite easy here. There are two types of the patients: those who have a resection of mucous level, and there was found some precancer lesion, and then they should be removed, or whether ablation should be done after the resection of mucous. Yes, it should be done, because it's a very good form to make sure that adenocarcinoma is not restored, because in every third patient it takes place. As for primary eradication of the Barrett esophagus, there are quite many questions here. They're asked by our patients, especially because they have cancer phobia that is promoted by mass media. Well, doctor says that the risk is quite low, and the risks patients, the risks are not very healing for the patients. Here you can see a slide prepared by the Best Academy that is headed by Alexander Repic, and a number of European specialists have been involved there. If we talk about primary ablation, it doesn't include it in the protocol of treatment of patients with Barrett esophagus, and only selected patients underwent that procedure. As for the Russian well, situation is quite bleak here, because no technology officially registered abroad had been applied and registered in Russia in 2016, 15, 16. At least new officially registered technologies were launched in Russia. And now you can get to know with a high-frequency ablation that is recognized globally. I don't want to talk a lot about it in details, and among all methods, it's one of the quickest and safest ways to do prophylaxis of consequences or complications, and the protocol is well known as well, and the additional procedure is hybrid APC. When a water pillow between the muscles and mucous is the condition for prophylaxis of consequences. Making a resume, endoscopic diagnostic of early changes requires good equipment, good endoscope, needs high resolution, chromendoscopy, virtual chromoscopy, and so on. Trainings and experience are key to success. There are lots of internet resources that allow to see or feel what kind of lesions take place at mucous. I don't remember the name of the website, but there is a group that makes diagnostics of the Barrett esophagus. Standard endoscopic treatment has 2 stages. We need to make resection, get material for pathologies of all lesions, and do ablations of the whole segment of metaplasia. Certainly, repeated examinations shall be done, usually once in 3 years. Thank you very much, Kirill. Thank you. As always, you have been very informative. Well, dear colleagues, are there any questions or comments to Kirill? Sergey? Well, I have a question regarding the structure of cancer incidence. If we talk about esophagus, recommendations we've been talking about. If we talk about the Barrett, they were launched quite a long time ago in Gastroenterological Association of the Russian Federation. Took part in developing them, and quite many conferences covered those recommendations and the topic, but yet it does not give us very significant results. If we talk about early diagnostics of adenocarcinoma, what shall be done? If we talk about practical approach, in order to improve detection of adenocarcinoma at early stage and change the structure of incidence, so we are in line with the global trends. Well, it's difficult to say, because as for the healthcare, our center is among the tops in Russia. Yeah, questions of screenings are not relevant, because we focus, it's certainly being done, but from philosophical point of view, I shall say that we should improve the quality of diagnostics at the lower level, and so I hope that will help this to improve the situation. Well, maybe that what could be done. Thank you, Kirill. What about our expert group, Alexander, Michael? Do you have any comments?
It was very, very great lecture. Thank you.
Well, just a short comment regarding Barrett's. I think there are 3 things we need. First, high-resolution endoscopes, no fiberscope in 2020. Second, training. You only find the lesions you know. And third, chromoendoscopy, which can be either electronic filtering or optical filtering or very cheap acetic acid.
Спасибо большое. Еще есть ли у кого-то комментарии или вопросы?
Thank you very much. Are there more questions or comments? Okay, so let's give applause to Kirill for his interesting lecture. Dear colleagues, today we have heard a few very interesting reports, and I would like to ask our expert group at the end of this session to say a few words about important things that we have been discussing today. Who wants to be first? Sergey, would you like to be? Or Linda? Just say. I think our international colleagues shall be the first, but I would like to say what is very important to me and to Russia. I believe that if we take endoscope, it's a very high-tech, expensive equipment, state-of-the-art equipment that is assembled by hand by people on Japanese plants that think thoroughly about details and nuances. So if we decide to deal with such high-tech equipment and use it in our everyday practice, our endoscopy and all approaches we use shall also be very thorough, very detailed. We have to develop a plan for each surgery, for each procedure. It should be based on the recommendations and standards. I believe that we did our best in sharing those important things with our audience. It should be understood by all endoscopists, experts who deal with such amazing equipment. Sergey, very interesting. Thank you very much. Zalina, do you have any comments? Kirill? Nothing to say, actually. We have discussed everything. I quite agree with all the speakers. I think we should set requirements not only to the equipment but to ourselves. The more strict we are, the more experience we get, the more efforts we invest in our work, in our upgrade, in what we do. You know, we should think more with our head, but not work with our hands only. And I believe that if we apply this intellectual approach, we'll do our best. Zalina, what about you? Well, I hope that young people that are today in the audience and who come to our training project will help us to improve their results. I also hope that you as senior managers will help us to upgrade laws, dear experts. Linda, Michael, Alexander, do you want to say a few words at the end?
Thank you. Just a few words. I would say that when you travel around, every country is dealing with quality of endoscopy. And no country has it perfect. And every country is doing it a little bit differently. But you always need tremendous leadership. And you have that here in Russia for sure. And I think that the initiatives that we've heard about are moving the ball up the field, as we say. Moving the ball up the field, and it's tremendous work, and it needs to be really recognized and congratulated. Terrific. So thank you.
Спасибо большое за эти добрые слова.
Thank you very much for your kind words. Alexander, would you like to say something?
To echo what Linda said, this debate is witnessing how good you are doing in this field and how much effort you're putting in improving yourself. This is not easy, and we really appreciate coming from other countries, seeing all of you working against to fight colorectal cancer. Congratulations.
Спасибо большое, Александр.
Thank you very much. Michael, what about you?
Well, just 3 sentences. First, to the patient. As you can see, we're all trying hard to improve our outcome in endoscopy. And although endoscopy is not always a nice procedure, it is an important and really helpful procedure, both for diagnostic and therapeutic. Second, to young colleagues, you have great leaders in this country who push the limits of what's possible today, and the technique and technology is rapidly evolving, and endoscopy is an exciting field to work with. And third, to my friends and colleagues here on the board, you've done great work. We're all dealing with the same problems. In some issues, we may be in front of Russia. In other issues, we are behind of Russia, at least when it comes to working together to coming up with nationwide quality initiatives.
Спасибо большое, Майкл. Ну что ж, уважаемые коллеги.
Okay, dear colleagues, thank you very much. We heard wonderful words and feedback, great feedback of our expert group. At the very end, I would like to say thank you to organizers of this assembly and this endoscopic meetings. I would like to say thank you to our distinguished colleagues, expert group. Our discussion was very interesting, very lively. Thank you very much, and thank you to our international experts for coming to this assembly. Thank you for your fabulous presentations. Your opinion is very valuable to all of us, and I would like to say thank you to our national experts, Zalina, Kirill, Sergey, and all other speakers. I believe this meeting was very interesting to all of us. Thank you. Thank you. It really has been interesting to me. Okay, let's wish luck and all the best to each other, and see you all next time. Thank you, dear colleagues. And now there is a final of the championship on colonoscopy. Let's support our